Hi, and welcome to today's lecture brought to you by the Arizona Department of Health Services, Bureau of EMS and Trauma. I'm Dr. Amber Rice, and today's lecture is going to cover COVID-19 trends, medical decision-making capacity, and patient refusals. Here are the objectives for today's lecture. First, we're going to go over why this topic is so important now and what changes have occurred during the COVID-19 pandemic. We're going to discuss the risks of refusals and what an appropriate refusal is. And then we're going to go through some difficult cases together. First, I'd like to bring your attention to the ACEP and NAEMSP joint statement on this topic. The American College of Emergency Physicians and the National Association of EMS Physicians have stated that patients have a fundamental right to refuse medical care. However, it must be voluntary, informed, and patients must have the capacity for refusal. The rest of this lecture is going to break down this statement so that we all have a great understanding of what this means. There were some collateral effects of COVID-19 on medical care in this country. For months, doctors' offices were closed. Elective surgeries and procedures were postponed and canceled in many cases. And many patients were transitioned to telehealth appointments with their physicians. Telehealth appointments are very effective for many types of patient care. However, they're obviously limited in their ability for physical exam, vital signs, etc. So you can imagine that if we're not able to monitor a patient's blood pressure or hear new onset AFib or a new heart murmur, that we could be missing some really important diagnoses that would go unnoticed. Patients also missed routine care throughout the pandemic. They delayed regular checkups with their primary care physician and delayed dental and vision appointments as well. Patients also delayed or missed diagnostic and medical screening tests, which are meant to catch very important medical conditions like cancers and coronary artery disease. This has led to a delay in diagnosis for many important health conditions, including cancers, coronary artery disease, and risk factors related to stroke. What this has resulted in is an overall increase in the acuity of patients that we see. So think about the calls that you go on now compared to the calls pre-COVID. For patients with chest pain and stroke, we know that they have been waiting longer to call 911 or go to the emergency department. And data from the Arizona Department of Health Services supports what we're all feeling in the field, that we have more and more patients who are sicker than ever. So what does all of this have to do with refusals? All of the factors that we have just discussed have resulted in an increased number of high-risk refusals in the pre-hospital setting. We've had an increase in acuity of patients refusing care, and an increase in the age of patients refusing care and refusing transport to the hospital. We still have a lot of patients who are very fearful about going to the hospital for fears of contracting COVID. And sometimes the diagnosis might not be as obvious due to delays in preventative health care. If a patient hasn't had any preventative health care for over a year, abdominal pain, chest pain, other symptoms may be something more serious than it would have been a year ago. Next, I'd like to go through some recent statistics from Arizona that really do show this changing picture of pre-hospital care after the COVID-19 pandemic. This first study comes from Tucson. These are patients who received naloxone for an opioid overdose and subsequently refused transportation to the hospital. 2019 data here is shown in orange, and 2020 data is shown in blue. So we'll see that after the onset of the pandemic, after the shutdown occurred, there was an increase in the number of patients who received naloxone for an opioid overdose and subsequently refused transport to the hospital. Patients who suffer an opioid overdose are a very high-risk population of individuals. They have a very high risk of mortality in both the short and long term related to their substance abuse issues. In this single EMS system, there was more than a twofold increase in the rate of refusals after non-fatal opioid overdoses. We don't just see this trend in opioid overdoses. We see higher refusal rates in other high acuity call types as well. If you look at calls for chest pain or calls for TIA, you'll see that we have increasing numbers of refusals in 2020 for these high acuity call types as well. So this just means that patients with more serious complaints are more likely to refuse care following COVID-19. We also see this trend in older individuals. So if we look at refusals by age group, 2019 data is shown in blue and 2020 data is shown in teal. You'll see this trend of increasing refusal rates in particularly the older population. What this means is that this high-risk group with a higher mortality and morbidity are refusing at higher rates than they were before. This trend in increasing refusals can be seen on a month-to-month basis. If we look at 2019 data again in blue and 2020 data in teal, you'll see that after the onset of the pandemic, we had increasing numbers of refusals overall from patients not wanting transportation to the hospital. What this means is an increased risk to EMS agencies and providers on these refusal calls. Patient refusal calls have always been some of the most dangerous and risky calls for the EMS providers respond to, and this isn't necessarily because of the situation they're presented, but because of the liability or the risk of not taking a patient to the hospital. This liability doesn't necessarily result from a patient being sick and not going to the hospital, but can simply be from not performing a complete assessment. If we miss any signs or symptoms of a major illness during our assessment, or if we don't properly document everything that was said, done, and witnessed during the call. Another source of liability on refusals is not identifying that the patient lacks the ability to make an informed medical decision at the time. There is liability or risk related to refusal calls, even when providers do their best to counsel a patient who wishes to refuse, and if they've signed documents acknowledging that conversation that you've had. If we look at research involving EMS liability, refusals have led to more than half of EMS litigation. So simply having the patient sign the document or having that conversation with the patient doesn't mean that there isn't a risk for liability if there is a bad outcome related to that call. Here are a couple of examples of EMS refusals that have resulted in lawsuits. This first call is from Pittsburgh during a snowstorm, where an individual called 911 10 times over a 30-hour period for abdominal pain. There were recorded statements from the crew that demonstrated their unwillingness to make a sufficient effort to help the patient. When the patient was unable to walk to the ambulance in the snowstorm and the crew was unwilling to walk to the patient to perform an assessment, this patient ultimately died, and as a result of this call, the patient's family filed a lawsuit not only against the city, but 3 EMS officials, a paramedic, and 3 EMS supervisors, and a dispatcher. What this call highlights is that the importance and the due diligence of performing an assessment is important on every single call. Even if you've gone to a call on an individual 15 times in a single day and performed an assessment every single time, if you don't perform that assessment on that final call and there's a bad outcome related to that, then the liability will fall squarely on the EMS providers who refuse to perform that due diligence and do the appropriate assessment and the appropriate documentation. The next case comes from Washington, D.C., where a mother had called 911 for a child with shortness of breath. The EMS crew had come in and completed a refusal, and subsequently the patient had died of pneumonia. The allegations for this case stated that the crew entered the home with only a stethoscope and that the lead paramedic determined that transport was not necessary. The mother was told to take the child into the shower and run the hot water to create steam to assist her breathing. This call resulted in a paramedic being placed under criminal investigation and a lawsuit being filed against the city and the medical director. What this case highlights is the risk of what we call paramedic-initiated refusals. In other words, an EMS provider making the determination that the patient does not seem ill enough to require transportation and convincing the patient to stay at home, even if the EMS crew had come in and done a complete assessment and the child was very well appearing, vital signs were normal at the time. Simply the act of suggesting that the patient was not ill and didn't need transportation to the hospital can generate risk, and you take on that liability even if the patient ends up signing a refusal form and not going to the hospital. It's important that patients who are refusing care or refusing transportation are doing so because they've made that decision, not because we've suggested or we've convinced them not to go to the hospital because of our impression that they're not sick. What are some of the pitfalls in performing an EMS refusal? There is pressure or a desire to clear the scene and return to service after completing a refusal. A complete assessment of a patient and taking the time to inform them of the risks and alternative care takes time to do, and this is at odds with the pressure or the desire to clear the scene and return to service. Another thing that can happen is an assumption that the call is of a lower acuity because the patient is refusing care or refusing transportation. We have to remember that just because someone is refusing care doesn't mean that they don't represent a very high-risk individual or that this patient isn't very high risk for a bad outcome in the short term or long term. What is a refusal of care? A refusal is a decision by the patient to forego all or part of a medical assessment, treatment, or transportation. A patient can agree to one treatment and still refuse another, meaning that medical decision-making is not all or nothing. Patients may make decisions based on one or more reasons. It can be based on evidence or simply their beliefs about something. And patients retain the ability to make decisions even if it's likely to lead to a bad outcome. Our responsibility as EMS providers are to provide information to help patients understand their condition and not just check a box on a form that we've provided information. We really are responsible for providing them information and helping them to make a decision with the best available information. Assessing and documenting that an individual has the ability to make an informed medical decision is more than just A&O times 4. It's important to assess for cognitive impairment, so assessing whether or not they're alert and oriented, if they're responding appropriately to questions, and if they're significantly impaired by drugs or alcohol. This is only part of the picture, however, because making an informed medical decision also means that the patient can understand the situation. So do they understand what is happening and what could happen? Do they understand the risks and benefits of refusing care or the care being offered to them? And do they understand the alternatives to treatment and have a plan of care if they were to get worse? The other important piece to this is that the patient is not influenced by family members or EMS providers, that they're making their own decision. These are all the necessary parts of your assessment for the ability of a patient to make an informed medical decision, and also important to document your conversation of each of these parts. Obviously, one of the first things we usually do when we assess someone's decision-making abilities are assessing their cognition. There are multiple different parts of assessing cognition. One of them is orientation. So A&O times 4 is not their ability to make an informed healthcare decision, but it is important to assessing their cognition and potentially their ability to make a decision. So what is the individual's relationship to their world? Do they know where they're at? Do they know who they are? Do they have a basic understanding of the situation or what's going on around them? This is the orientation piece, and it is important as part of your assessment of their cognition. So a take-home point about assessment, A&O times 4, is not an ability to make an informed healthcare decision. And the next part about assessing cognition is assessing and documenting that the patient is not impaired. Patients can be impaired by a variety of medical or psychiatric conditions, including alcohol or drugs, mental illness, acute neurologic insult such as stroke or trauma, metabolic derangements, hypoxia, hypotension, hyper or hypoglycemia. These are all reasons why patients can be impaired, and it's important to assess whether or not the impairment is so great that it's impacting their ability to make an informed decision. Sometimes we use screening tools such as the 6-sided cognitive screen to screen for cognitive impairment. What's important about using the screening tools is, one, they have to be performed correctly to be documented and accurate, and these scores do not determine the ability to make an informed medical decision. These screening tools are an assessment of cognition. And the last piece of the refusal assessment is your assessment of their situational understanding. Do they understand what medical condition they're presented with? And do they understand the risks that they take if they don't get treatment? There are a lot of questions that you could ask to help you assess and to document a patient's situational understanding. What do you think is wrong with you? What treatments or transportation have we suggested? What could happen if you don't get this treatment? And why are you refusing this treatment or transport? These are all important not only to get an understanding of why the patient is refusing and find out if there are some reasonable alternatives that we could suggest, but also to make sure that we're documenting this conversation with the patient. Making an informed medical decision refers to a specific circumstance at the current point in time. This doesn't mean the decision that they made yesterday or the day before, but this means at the current time, do they understand what's going on, and are they able to make an informed decision about their current situation? They could have the ability to make an informed decision in simple situations, but more complex healthcare conditions, this might be much more challenging for them. So this needs to be reassessed with each decision and at each different encounter. This is especially true with patients who have dementia or other forms of cognitive decline, where their ability to make an informed decision is a little bit more challenging to assess on a moment-to-moment basis. And a very critical point regarding refusals is this idea of undue influence. So the very important part about liability and risk in patient refusals is that the patient needs to make the decision without influence from others. And this could include family or friends, as well as us on scene. For example, if you go on a chest pain call and the patient's family member states that they think they're just being dramatic, they don't think that they're very sick and that they don't need to go to the hospital, this is a very risky situation for EMS. It's important in these situations that the provider assesses the patient's decision and what the patient would like to have happen. The risk is when the patient refuses care but is unduly influenced by a family member or friend who's trying to convince them not to go to the hospital for further assessment. So how do we perform an appropriate assessment in a patient who's refusing care? Like we said, these are very high-risk encounters, not necessarily because the patient is ill, but because we might not be taking them to the hospital. So it's very important in these cases, much more so than in cases where we're taking the patient to the hospital, to perform a very full and detailed assessment. This includes a history of the present illness, a documentation of what's going on and what has been happening. It's also important to document a past medical history, current medications, and perform a full head-to-toe physical examination. Many times we're used to performing very focused assessments on patients because we're assessing a very specific complaint and planning on taking them to the hospital for further evaluation. When we're not taking someone to the hospital for further evaluation, it's even more important to perform that full head-to-toe physical exam and document your findings. Our neurologic and cognitive exam is the other important piece to document, which evaluates the patient's mental cognition and their neurologic status at the time of the evaluation. Let's go through a couple of cases. The first is a 25-year-old male who's been drinking alcohol since 2 p.m. He gets into an altercation with another individual and is struck in the head with a bottle. He has a 4-inch laceration to the scalp and wants to refuse treatment and go home by himself. Is this a reasonable plan? I would say that this obviously depends on our assessment of the patient at the time. However, in cases like this, I think it's very difficult to tell whether or not the cognitive impairment is due to a significant head injury or drug or alcohol intoxication. And so these cases tend to be very high risk because it's very difficult to tell whether or not the patient has a condition that's going to wear off in a couple of hours or if this is a condition that's going to continue to get worse. Is the patient able to understand the concern about the possibility of a head injury that could be significant and potentially lead to death? Does he have a plan for getting the laceration fixed? Is he able to control the bleeding of the scalp laceration? All of these things are really important to suss out during the call. However, just based on the nature of this type of injury, it presents a very, very high risk refusal for EMS. The next patient is a 75-year-old patient with terminal lung cancer. His family was nervous and called 911, and when you arrive, the pulse ox is 85% and he has a very high work of breathing. He tells you that he's on hospice and that his oncologist has told him that there are no further treatment options. He tells you, "I'm going to die. I understand this and I have come to terms with this. My family is scared, but we have discussed this and made the appropriate arrangements." Is this a reasonable decision? Now, this patient has a long-term chronic illness. He knows the potential outcomes of his illness and has discussed this at length already with his oncologist. And it appears that he is cognitively intact and able to make this decision on his own. So obviously this presents a much different situation than the previous case. Obviously this patient is a high risk for a bad outcome. However, in this situation, the bad outcome is predictable and the patient knows that he is likely to die from his condition and is able to articulate this to you. Documenting a patient refusal is one of the most important parts of these encounters. Because of the risk involved in not taking patients to the hospital, a well-written patient refusal document really does provide a lot of protection for the provider and the EMS agency. A well-documented refusal demonstrates that the crew has fulfilled its duty to act and adequately determine the patient's mental status and ability to understand the situation. Documenting a patient refusal is one of the most important things to document. A well-written patient refusal document can protect the provider as well as the EMS agency. A well-documented patient refusal demonstrates that the crew has fulfilled its duty to act and adequately determine the patient's mental status and their ability to understand the situation. It can and should take longer to document a patient refusal than a normal PCR. Oftentimes, we rush through these examinations because the patient isn't going to go to the hospital, but in these situations, due to the risk, it's more important than on those other calls to do a complete assessment and fully document that call. It may seem a little bit frustrating because many of these patients do have a lower acuity complaint. However, because of the possibility of a bad outcome and not taking them to the hospital, it really does protect you to take the time to ask those important questions and document your full assessment. So in an appropriate refusal, the patient understands what is going on currently. They understand what you are offering to them and the alternatives that you could offer. The patient is making their own decision to refuse care and is not being unduly influenced by a family member or ourselves. And the patient is not impaired to the point where they are unable to make that decision. Let's go through a couple more cases because a lot of these refusals are very complicated. Can someone who is drinking or using drugs have the ability to make an informed medical decision? Yes, but the key is that we ask the right questions to determine if they can make an informed decision. And they must be able to communicate clearly the decision and the reason for making the decision. Alcohol intoxication does not necessarily render a patient incompetent. We have to determine in each situation if the patient at that time has the ability to understand the risks and make an informed medical decision. We also cannot use the alcohol level to determine whether or not the patient has the ability to make an informed decision. So here's another case scenario. A family called 911 after finding their 23-year-old daughter unresponsive. She has a history of heroin use, and the family had given intranasal naloxone. When EMS arrives, the patient is awake, alert, and oriented, and now she wants to refuse transport to the emergency department. So think a little bit about this case because this does happen from time to time. The crew patches for an ALS refusal, and the physician talks to the patient over the phone. When they ask the patient why they don't want transport, they state, "This has happened before. All you do at the hospital is watch me and then I go home." When you ask if she understands that she may lose consciousness and stop breathing when the Narcan wears off, she states, "I know, but my parents have another dose of Narcan." Does she have the ability to make an informed medical decision? So at the time, if the patient is alert and oriented, if their cognition is not impaired by drugs or alcohol currently, and if they're able to articulate what the risks are and what the alternatives to treatment are, then yes, the patient has the ability to make this informed medical decision at the time. Is this patient at risk for a short-term or long-term bad outcome? Absolutely. Which is why it's very important to fully document this conversation and everything that was done, and that we encourage the patient to go to the hospital, and that we provided as much information and support that we could, and that the patient still wanted to refuse care. But performing that full assessment, doing our due diligence on scene, really does help protect us in the event of a bad outcome. What about patients with dementia or cognitive problems? Patients can have a diagnosis of dementia and still have decision-making capacity. With patients with baseline cognitive impairments, we have to make sure that we ask very specific questions about the case to determine if the patient has the ability to make an informed medical decision or refuse care. Here's another case scenario. This one is a 73-year-old male who was in an altercation in a home with his son. The police department had called EMS to evaluate the patient, which happens quite often. In our assessment, he has vital signs, including a blood pressure of 202/108, a heart rate of 84, he's saturating 98% on room air, and has a blood glucose of 120. His history of hypertension, and he takes medication for this. Patient has dementia, but the crew states that he is A&O times 4. The wife reports that she is his power of attorney and would like the patient transported. So think about this case and think of some of the things that you would like to ask this patient. The patient states that he wants to stay home with his family. The physician talks to the patient over the patch phone, and he explains to the physician why EMS and the police department were called to the house. When the physician asks about his high blood pressure, he states it's normal for it to be very high, and he can give the name of his medication, losartan. So what other questions might you ask the patient in this scenario? The patient was able to correctly provide the year, month, city, and state. When asked what could happen if his blood pressure stays elevated, he says, "It'll destroy my organs, but I don't want that to happen." He then states, "If my son and I stop having altercations, my blood pressure won't be so high." Does this patient have the ability to make an informed medical decision? So the patient has demonstrated that he's alert and oriented. You've been able to evaluate that he's not significantly impaired with drugs or alcohol. And he's able to articulate an understanding of his current medical problems and what the risks of not getting treatment for those would be. So yes, in this situation, this patient is demonstrating the ability to make an informed medical decision. If one of these cases comes up and you need assistance in determining a patient's decision-making capacity, or if there's some confusion about documentation or medical powers of attorney, you can always contact medical direction in these cases to help sort out what the best thing to do would be. So always remember that refusals are the highest risk patients that we see in pre-hospital care. And this is mainly because we are not taking them to the hospital for definitive care. So it's really important that we do a full assessment and document a patient's ability to make an informed medical decision about that refusal. We have to make sure that we avoid the pitfalls of assuming a low acuity just because the patient is refusing care or refusing transportation, and rushing to complete the checkbox in the ePCR to clear the scene and get back in service. We want to make sure that we're not influencing a patient to refuse care or allowing others to influence the patient to refuse care. When in doubt, or if there is a very high risk situation, we can share this burden. We can contact online medical direction, document that conversation with the patch physician, make sure that someone else is corroborating the documentation that we're providing about the patient's ability to make an informed healthcare decision or an informed refusal in a high-risk situation. So from the Arizona Department of Health Services, Bureau of EMS and Trauma, thank you very much for joining our lecture today.